to their patients if she's elected governor. Before we begin, I want to note that these physicians are speaking as individuals and part of the Committee to Protect Healthcare, not necessarily on behalf of any employers. So we respectfully ask that you please only refer to them in any coverage as they introduce themselves, and please do not include employment information unless they expressly share that. So thank you in advance for being respectful of that. Without further ado, I will introduce our first speaker, Dr. Erin Stevens.
Hello, thank you for joining us today. My name is Dr. Erin Stevens. I'm an OBGYN hospitalist in the Twin Cities and co-chair of the Minnesota chapter of the Committee to Protect Healthcare. After a chaotic primary race that ended earlier this week, Lisa Demuth has emerged as the Republican nominee for Minnesota governor. Her record on healthcare, particularly reproductive healthcare, concerns me deeply as someone who cares for people through some of the most significant and consequential moments of their lives. Lisa Demuth doesn't just personally oppose abortion, she has repeatedly worked to restrict the ability for Minnesotans to access this safe, evidence-based healthcare. In the wake of the Dobbs decision, she not only voted against the PRO Act that enshrined abortion rights in our state constitution and the Reproductive Freedom Defense Act that protected patients and providers, but she chief authored HF 1809 in 2023, a bill that would have in multiple ways infringed upon bodily autonomy and personal medical decision making for abortion in some of the most difficult circumstances. This year, Minnesota Citizens Concerned for Life, or MCCL, endorsed her candidacy. This was unsurprising, as her legislative record has indicated that she has voted in alignment with MCCL's anti-abortion agenda 100% of the time. That is extreme. That is out of step with Minnesota voters. And as I know from my experience as an OBGYN physician, that is dangerous. Decisions around abortion should be left to patients with the support of their trusted loved ones and providers. There is no room for politicians like Lisa Demuth in our exam rooms. Unfortunately, it's not just reproductive health care that Lisa Demuth wants to rip away from Minnesotans. She also supported H.R. 1, President Trump's one big, beautiful bill, legislation that made the largest cuts to Medicaid in the program's history. Medicaid is utilized by approximately 1 in 4 Minnesotans and covers 35% of births in the state. These monumental cuts are projected to cause as many as 161,000 Minnesotans to lose their health care coverage. That means 161,000 more of our neighbors without access to health care, treatment for their chronic medical conditions, preventative care, contraception, prenatal care, and postpartum care. I'm scared for the health and futures of my patients who rely on Medicaid and may no longer be able to receive the care they need, especially for time-sensitive issues around pregnancy and childbirth. I've seen what happens when patients aren't able to get prenatal or postpartum care. Patients who arrive to the hospital pregnant and bleeding, full of both worry and hope, unsure even how far along they are in the pregnancy, only for us to find out together as we watch the ultrasound screen desperately that their term pregnancy no longer has a heartbeat. Patients who never return for blood pressure follow-up as advised due to concerns during their postpartum hospital stay, and then woke up in an ICU bed after having seizures at home. Patients with entirely preventable tragic outcomes because they couldn't see a doctor when they needed to. Kicking patients off of their health insurance, thereby reducing or eliminating access to prenatal and postpartum care while driving forward a political agenda aimed at banning abortion, is truly terrifying. That's why we're here today. As a physician, I am compelled to speak clearly when political agendas threaten the ability of my patients to access life-saving health care. Minnesotans deserve a governor who trusts patients and doctors, not politicians, to make medical decisions. And based on Lisa Demuth's record, I am deeply concerned that she would take Minnesota in the wrong direction. Thank you. And now I'd like to welcome Physician Assistant Heather Dale to speak.
Thank you, Dr. Stevens. Hello, my name is Heather Dale, and I have been a physician assistant for 22 years. I am also the director of a college health clinic in rural Minnesota, where I've worked for the past 18 years. I want to focus today on a healthcare issue that is especially important to those of us practicing outside of the Twin Cities, whether our rural healthcare infrastructure will be strong enough to meet the needs of our communities. The reality is that many rural hospitals and clinics are already under enormous financial pressure. The Minnesota Hospital Association reported this year that nearly a quarter of Minnesota hospitals meet the state's formal financial distress criteria. Rural hospitals are particularly vulnerable, with some already cutting services in order to remain open, including the community hospital in our town. When a rural hospital closes a service line, patients may have to drive an hour or more for care, and this is particularly challenging for my patients who often don't have a car. When a hospital closes altogether, the consequences affect emergency care, obstetrics, surgery, primary care, and the ability of a community to recruit and retain healthcare professionals. This is all happening at a time when Minnesota's rural communities are already facing significant challenges with workforce shortages and access. Last year, when changes happened in our town, it left a massive void, placing immense emotional, financial, and at times physical strain on our patients. For one individual, without a car and facing prolonged wait to see specialists and get care, our college health clinic became a vital lifeline. The patient visited us 3 times a week for weeks on end, simply for basic monitoring and reassurance. But without our safety net, that patient would have most certainly ended up in an emergency room. And unfortunately, their story isn't unique. Every week, I hear similar struggles from local families fighting just to access basic care. This is why the federal Medicaid cuts from H.R. 1 are so concerning. H.R. 1 is projected to reduce federal Medicaid spending in Minnesota by billions of dollars over the next decade. It's estimated that this law could reduce federal Medicaid spending in rural Minnesota by approximately $4.34 billion over the next 10 years. It also warns that these reductions could increase financial pressure on critical access hospitals and small rural facilities, increasing the likeliness of service cuts, layoffs, and additional closures. The Medicaid cuts in H.R. 1 were the last thing that rural hospitals and communities needed. And, unfortunately, Lisa Demuth supported H.R. 1. As a healthcare professional working in rural Minnesota, I believe our elected officials should be working to protect and bolster rural hospitals, not to undercut them. They should prioritize ensuring patients have access to healthcare as well as healthcare facilities near them. If fewer people have insurance, hospitals receive less reimbursement. And if hospitals receive less reimbursement, an already fragile rural facility may have fewer resources to maintain services and recruit staff. And if services disappear, patients have to travel further for care. And when they are dealing with healthcare emergencies, every minute counts. Minnesota has an opportunity to strengthen rural healthcare and to protect access close to home. We should be moving in that direction, not adopting policies that put additional financial pressure on our rural healthcare system. Now, I'd like to welcome Dr. Muthiala to speak.
Thanks, everyone. My name is Brian Muthiala, and I'm an internist and a pediatrician practicing locally in Minnesota. I come today not representing a specific health system or any private interests, but come sort of to give voice to all the patients that I've cared for over the last 15 years during my career. As a physician, I see every day what happens when patients cannot afford or access the care they need. A medicine gets skipped, appointment gets postponed, a chronic condition is left untreated. And eventually a problem that could have been managed in a doctor's office becomes an emergency. And that's why I'm concerned about Lisa Demuth becoming Minnesota's next governor. Her record gives us a pretty clear picture of the healthcare policies she has supported. We can start with Medicaid, as my colleagues have mentioned. As Speaker, Lisa Demuth supported President Trump's H.R. 1, which slashed Medicaid funding. As we have heard, this could mean that 160,000 Minnesotans could lose access to healthcare. And those aren't just numbers. Those are my patients, my friends, our neighbors, people that we see every day. Routinely, I have patients who skip appointments. They stretch essential life-saving medications so they last 2 months instead of one. Patients who forego preventative care, wait till their symptoms are so severe they have no choice but to go to the emergency room. And all of that just leads to worse health for the people of Minnesota. And instead of increasing barriers to care, we should be working to protect these patients, not taking away their health care. And unfortunately, uh, uh, Lisa Demuth's healthcare record has shown us how she feels and gives us additional causes for concern. In April of 2023, Lisa Demuth voted against holding Big Pharma accountable for skyrocketing prescription drug prices. We have patients that ration medicines because they can't afford them. We have patients that decide which prescriptions they can fill this month. We have people with diabetes who take less than the insulin they should be taking because they struggle with its cost. We have patients who stretch their antihypertensive medicines and are willing to ride with a higher blood pressure just so that they can take something a little while longer. But Lisa Demuth sided with Big Pharma instead. She opposed the legislation in 2020 that established the Alex Smith Insulin Affordability Act, which was designed to make insulin more affordable and ensure access to this life-saving medicine in emergencies. And then, as we heard before, there is her record against reproductive health care in the state. A governor can have enormous influence over whether Minnesotans can afford their medicines, whether hospitals can keep their doors open, and whether patients can access the care their doctors and providers recommend. And now Lisa Demuth has won the Republican nomination for governor. So this isn't simply a discussion about her record as a legislator. Minnesotans will have a choice to decide what kind of healthcare system they want their next governor to lead. I believe we need a governor who will listen to providers, nurses, and most importantly, the people of Minnesota to protect patients' access to care, make prescription drugs more affordable, and respect the ability of patients and doctors and providers to make medical decisions together. And I hope Minnesotans will look closely at Lisa Demuth's record and understand what it could mean for patients we care for every day.
Thank you so much, Dr. Mutiala, and all our speakers. We'll open it up for questions now. If you have a question for one or any of our speakers, you are welcome to raise your hand, and I can allow you to unmute to ask your question verbally, or you are also welcome to type your question in the chat box or the Q&A function, and I can help read those out. So we'll allow a few moments for folks to be able to raise their hand or type their questions. I had one that looks like it was chatted just to me, so I'm going to put it in the chat box for you all to see. Abortion access is protected in the state constitution and in law now. Why are you still concerned that Demuth could restrict access? That's for any of you.
I can certainly take that one. We are very lucky to be in the state of Minnesota where we have advanced reproductive freedom, but we know that that could always change at any time. For the longest time, when we were concerned about Roe v. Wade falling federally, people told us, don't be worried. Roe is the law of the land. And then the Dobbs decision happened, and here we are. Depending on who's in power, things could very much change. And even since the PRO Act, we've seen many pieces of legislation proposed that would restrict access to this really safe, evidence-based healthcare. So as long as I am a doctor in this field, I will continue to be concerned about the ability for patients to access this care because we know that there are bad players out there who will continue to work to prevent people from accessing this care.
There's a question in the Q&A. If you could comment on the impact on emergency department care and boarding/crowding. Yeah, I'm not sure if that's about HR1 or, yeah, I guess open to interpretation for any of you.
Yeah, I can answer that. I mean, I think that when people lose access to healthcare through loss of insurance, what that leads to is higher visits to the emergency room. Emergency room will always take people regardless of their ability to pay. And so patients will come to the ER, and the emergency rooms will welcome patients and take really good care of them. The issue is that that will lead to limitations because it's just increasing numbers and patients who could get the ideal care elsewhere. This will lead to patients presenting later, so sicker than they may need to have presented. And so all of that is going to increase the burden that our already really taxed emergency departments have. And what that may lead to is when there are more people that come to the emergency department, that will lead to longer times waiting in the emergency room, longer times boarding in the emergency room. So patients staying in the emergency room longer because there are just less beds and things of that. And we've already seen significant issues across the state in terms of ER wait times and things of that nature. So, all of the impacts of people losing their insurance will certainly affect ER visits and ER boarding and ER wait times.
Thank you, and thanks for that question. There's another question in the Q&A. For Minnesotans who live in rural areas and seeking healthcare access, what policies do medical professionals advocate to ensure hospital stabilization? That's for any of you, and I'll read it again. For Minnesotans who live in rural areas and seeking healthcare access, what policies do medical professionals advocate to ensure hospital stabilization?
Well, I can start with that, and then anyone else can jump in, of course. I think access to affordable health insurance is huge. As we are seeing with HR1, that cut to Medicaid is going to drastically increase or decrease access and access to affordable health care. And we've seen across the country that health insurance costs are inflating astronomically this year. But for people that are in the lower or even the middle sections, that cost of healthcare and finding insurance that they can use will continue to become an increasing problem for them. And that will lead to the higher utilization in ERs. So it's kind of a chicken and an egg as far as which problem comes first. But if we do not support Minnesotans and we do not continue to fund the great healthcare that we've had in this state for so many years, we are going to see things spiral downwards very rapidly.
And to piggyback off of that, yes, we need to make sure people are covered by health insurance in the first place. The more uninsured population we have, they end up requiring emergency care that goes unreimbursed overall. But we need to make sure insurance companies are also doing their jobs. People are paying huge premiums, often for their insurance companies to simply automatically deny care. Let's use AI to, go through and just deny this care right away. And insurance companies should actually be covering this healthcare that people need, so that when they show up to the hospital, they're not going to get some denial and then have to fight to get their care provided. So when we see all of these, unreimbursed costs, hospitals have to eat that cost somehow. And those that are providing more care to uninsured people end up really being in financial strain. We saw this with HCMC. We're seeing it with North Memorial, that the safety net hospitals are the first to struggle. And if they're unable to come up with that money somehow, whether that's going to private equity or being bought out by somewhere else or having legislation to support them, those hospitals close. And we're seeing that in rural areas more, but it's creeping into these urban spaces as well. And the more hospitals that we see closing, now that puts an excess burden on the hospitals that continue to exist until it's just simply unsustainable. And when it gets that busy, now we have staff that are quitting as well. So we need to appropriately staff these places and support those staff. There's just so many issues going on at the same time that, there's not one answer that's going to fix everything. But we need to have politicians, lawmakers who are invested in seeing healthcare succeed and supporting it in all those multifaceted ways.
Thank you both, and thanks for that question too. There was another question chatted just to me. I'm going to put in the chat box for you all. Can any of you share a specific story of a patient who struggled because of the cost of insulin or other prescription drugs they needed? Again, that's can any of you share a specific story of a patient who struggled because of the cost of insulin or other prescription drugs they needed?
In OBGYN, often, I'll see not often, but I see from time to time patients who have gestational diabetes. They develop diabetes specific to the pregnancy, which comes with specific risks for the pregnant person and the fetus. And often we will prescribe insulin for that. And because insulin can be very difficult to access for many people, some people will end up not starting the medication at all. And that increased risk to their overall health with uncontrolled blood sugars, but also to the development of their growing fetus. Babies that grow exceptionally large have developmental abnormalities, things that can impact the mode of delivery and the safety of the birth as well, and can increase the risk of stillbirth. And so we see patients who don't start the medications that they need and absolutely end up with either just negative, kind of concerning outcomes or the worst outcomes like a stillbirth.
So the work that I do is primarily hospital based, and so one of the things that is nice about being a hospital-based doctor is when I discharge a patient from the hospital, oftentimes I can order their prescription medications and it's sort of wrapped up into their hospital bill. So routinely, I will have patients who didn't have any medicines. They've come into the hospital for a reason and they get a month's worth of supply of whatever that may be, their high blood pressure medicine, their diabetes medicine, their seizure medicine, you sort of name it. However, that medicine will eventually, the prescription will run out. And so just not that long ago, I took care of a patient who came in because of uncontrolled high blood pressure. They had been in the hospital. A few months prior, they had gotten a prescription for a month for their medication, and then that medicine ran out, and then they were unable to afford that blood pressure medicine. And over the subsequent few months, their blood pressure started to go up and up and up. And they came in and their blood pressure was extraordinarily high. It was a medical emergency. They needed to get put on medicines through the IV to lower their blood pressure very quickly because of the risk of stroke. And then they needed to be hospitalized for a few days after that to sort of get their blood pressure back into the right spot and to make sure any of the damage that had been caused by that uncontrolled high blood pressure for the last few months was sort of able to be sort of mitigated. And so, and that story is not an uncommon one, as we see patients routinely who are unable to get in to see their provider to get prescription medications. They are unable to afford those medications, and so they go without. This could be for diabetes, high blood pressure. You sort of name it. I would say that this is the lived reality of Minnesotans every day. Are people that are trying to make ends meet and are struggling between making really hard choices. It is not that people don't care about their health. People care deeply for the health of themselves and their loved ones. It is that they are deciding between paying their rent, buying food, buying their prescription drugs, and at some point something has to give a lot of times. And unfortunately, patients are put in that predicament, every day.
Thank you both. Thanks for that question as well. I'm not seeing any other questions at this time. In case there's any follow-ups, I'll leave a minute or so. But in the meantime, I'll share that we've been recording this. So if you'd like a copy of the recording, you can let me know in the chat now or send me an email where you RSVP to Annika@committeetoprotect.org, and I can get that to you later this afternoon. Yeah, so not seeing any additional questions, so we'll go ahead and wrap up today's call. I want to thank everyone for joining. Again, I know it's a busy time, so thanks for making the time. And thank you so much to our speakers. We really appreciate you all being here and advocating on behalf of your patients. Thank you all and have a great afternoon.